Welcome again here today. I am Laurel Barr. I am the chair of the was young physician section, now the early career physician section. Here today to talk about ultrasound, and I have the chair of the ultrasound section, Dr. Rob Ferre here, who is going to tell us a little bit more about the section and all the great things that you're doing.
Yeah, well, thanks, Laurel, for the opportunity to tell people. So the emergency ultrasound section's been around for quite a while, and we are, I believe, the second largest section within ACEP. So after you're the largest section, and I believe we're the second. We have about 16 to 1,700 members of our section. So we are like very involved in all things. Either we use the term point of care ultrasound or emergency ultrasound. Like we're very involved. And our section isn't just people who are, program directors, fellowship directors, but we want to encourage, just average people who are trying to help ultrasound related items within their emergency department. Like we have a ton of resources, and we actually have a subcommittee that's a community ultrasound subcommittee that sort of helps people, navigate things like setting up billing and coding, other type of infection control stuff that you may run into. So we're pretty broad in what we do and try to appeal to as many people as we can within our section.
Well, I didn't know you were that big, and honestly, I'm not surprised. I think this is a great section. You're doing a lot of great things. And one of the things I love about this section is that if emergency medicine is 50 years old, ultrasound's only 20, 25 years old. So you can be a student today who does a month just doing a couple of scans, and you might have more experience than your program director or myself who graduated 10 years ago. So you can get involved and you can be the expert even with just your area of expertise now. So with it being so big and having, I think, 20 subcommittees, there's lots of great places to get involved. You just got to find your niche and see what you want to do.
Yeah. So interestingly enough, 2001 was the very first emergency ultrasound guidelines that were published by ACEP through the as a policy, sort of with the help of the emergency ultrasound section to put those out. And so it'll be 25 years. Well, it is 25 years this year, but it'll be 25 years since the board approved those. And like you said, those were sort of key policy guidelines that really helped to sort of enshrine what emergency ultrasound was, because it was just growing, just like emergency medicine has grown. It was growing and has evolved a lot. And ACEP was a core and key part of helping to establish that guidance. Interestingly, those ACEP emergency ultrasound guidelines have been looked to by many other specialties and are held up by many other specialties as like the standard, because uh, people are using ultrasound everywhere, but they don't necessarily have professional guidelines. So ACEP did, remarkable work, and sort of our early leaders did remarkable work to define that and to help kind of enshrine that. So it's
Yeah,
been a
and really
journey.
find that we could use it point of care at the bedside with our knowledge, and it wasn't just in the domain of the radiologist. Like I can't take a CT scanner or an MRI scanner to a mountain to try and diagnose someone's fracture, but we can absolutely do that with ultrasound, which is kind of amazing.
That's right. I mean, there is no CT scanner or X-ray on the space station, but there are ultrasound machines.
Ah, a very good point. Space medicine, we can get into that too.
Yep,
A final frontier.
that's right. That's right.
Well, how long have you been involved in the section?
I've been involved in the section since really I graduated residency in 2006. And so I was involved. So Vivek Tayal was one of my early mentors. He was really the one that led the effort for those policy guidelines. And so I was actually in the military, as active duty military. And so, oddly enough, it was Vivek actually who'd also been in the military. So I had great mentorship through some of the early leaders. And so I've been involved, really my whole career. I spent a lot of time with our industry roundtable, which we have I feel like a very great group of physicians that work with industry to say, look, we need these things. And industry's been very responsive to us in like saying, yeah, we'll give you a cup holder that doesn't, pop out and fall onto the ground, or, we'll build cords that you're not constantly rolling over. So there's sort of machine factors. And then, we've done a lot of work with workflow to make it easier because it's just too complicated. And so we've really tried to work with other organizations, international organizations, to create standards to make it easier for physicians to document their ultrasound exams. So um, we have a pretty collaborative group, and a lot of, like you said, we have a lot of subcommittees, and they do amazing work, and are really involved. So we have a very active section, and we have great people that sort of help.
I mean, speaking of being an active section, I know you didn't want to brag about this, but I think you won a couple of awards last year.
We did. I think we had the best newsletter award, and I think there are some uh, best sections or most engaged sections, and so we've certainly won that award, and it has nothing to do with me, but it has to do with like the great members and the other great leaders that we've had in the section. So, like I said, we have a big section, like you said, but we also have like a lot of really amazing dedicated people that are just really engaged in the things that we deal with the point of care ultrasound space. So that's great.
Well, and lots of subcommittees that are organized, that are producing content, that are producing things that are clinically helpful at the bedside. And one of the things I appreciate as the community doc is the billing and coding part of it. Because in the community, I can do the images, but I really don't want to spend time dictating out everything all the time. And that's a huge barrier in community programs, is that if you don't have the infrastructure to save the images and code for them, then it's just not incentivized to do it. So taking those resources to your facility, if it's a new job, if it's a rural place, if it's a community group, you can really provide value there.
Yeah. I think it's good because it is the document that you need to talk to your billers and coders, because no one appreciates a conversation with their billers and coders, I feel like, right? And so it's great because
What are you talking about?
no, exactly. So every year, actually, the billing and coding section updates those um, CPT codes. In fact, they just 2 weeks ago updated the tables because there's new RVU tables associated with those CPT codes, and so those are updated. The other thing that we do is we keep an eye out for insurers who want to not pay us for our work. And so we work with the
I don't know
ACEP's
any of those either.
yeah, we deal with ACEP's billing and coding team to address those issues, because it seems like every year or two there's a new payer that decides, oh, well, we just don't want to, pay you for these codes because it's just inherent to what you do. And so uh, it's good to have an active subcommittee that deals with that, so that we can proactively address some of these issues. Because once one payer decides to stop paying us, they'll all follow suit. So
Isn't it great to have a section that's so core to what we do that they just think it's all included now?
yeah, right. That's exactly right. Well, and I think the other thing is we try to put out, as a section, we try to put out content that's helpful, right? So I think that the ACEP updates on the billing and coding are helpful for everybody. Um, We also have infection prevention. So that's an active group that works with other organizations like AIUM, other big sort of ultrasound organizations, to make sure that those guidelines are out there and that they are not um, overly burdensome for physicians, right? Because infection prevention is very important. Um, but it's good to have a physician that's like, no, we can't completely put the bed through high level disinfection. We can't put the entire ultrasound machine through high level disinfection. So, having that out there, that has been really helpful. Like one of the real things that our section's been involved in actually is ultrasound guided peripheral IVs, where a lot of local infection prevention people at local hospitals wanted to say, hey, if you use ultrasound for any type of procedure, it immediately needs to undergo high level disinfection, which all of us think is, I mean, imagine there's nurses at all of our places that are putting ultrasound guided peripheral IVs. And imagine every time you had to take off the probe and send it down to central or sterile processing to clean the thing. I mean, that's asinine and ridiculous. So the section worked with industry to um, and with other organizations to put out guidelines to say, no, you don't need to have these probes undergo high level disinfection, right? And also work with our industry partners to say, let's look at your manufacturer's instructions for use, which is what the Joint Commission looks at, to make sure that your language is reflective of best practices and there's not confusion. So anyhow, that was a lot of work from our section, and fortunately, if you're having that problem, we have infection prevention guidelines on the webpage to kind of help with that. So.
And I think that infection prevention guideline really became important during the COVID-19 pandemic when infection prevention was really, we'll say, very important. And then, yes.
Yeah.
But the other thing that I'm hearing is that because of the work of this section with making those infection prevention things not so practically burdensome, or not so burdensome practically, is that you're the reason why I can't do a cut down central line.
Hey, if you want to do a cut down central line, just have at it,
I don't think I can.
I know.
I don't know the list. I don't know if I've ever done one. Ultrasound diabetes has been around for that long.
I hope that we as a section help to get rid of the DPL, or point of care ultrasound help get rid of the DPL in trauma, and hopefully ultrasound help get rid of the cut downs that actually, when I was in Iraq, I witnessed a couple of cut downs by vascular surgeons, no less. And let's just say it didn't go that well. I mean, that's a tough, tricky thing.
It's a procedure. It's honestly
a procedure.
With everybody doing peripheral IVs with the ultrasound and nurses getting trained, it really helps that we'll say more burdensome procedures. And really with a whole lot of things, ultrasound's so helpful in decreasing radiation risk and really everything we do, so much so that it's so core that we don't get paid for it anymore, except for the work of the section.
Yeah.
But speaking about being proactive with the industry, with everyone, with technology, one of your subcommittees is AI focused, and that's one of your goals for this year. So tell me about that.
Yeah, so we had an emerging tech subcommittee, and we had a discussion with some leaders within the section and just some other sort of subject matter experts, and we took that emerging tech subcommittee and made it the AI and emerging tech subcommittee, because there are other technologies besides AI. I know it doesn't seem like it, but I mean, it's the main one. But the goal of that subcommittee this year has been a couple things. One is to provide education to the community, because I think AI is the new buzzword, and AI means, I think, something different to every single person, because we see a lot of change with AI, and it's a little bit hard for us to know what's AI and what's just advancing technology. And so in our newsletter, we've done some efforts to help educate our physicians what domains of AI affect point of care ultrasound. So computer vision specifically is the domain of AI that affects image recognition and image manipulation. And then you have like ChatGPT, which is a natural language processing AI domain. And of course, new versions of ChatGPT take NLP and computer vision and just put them all into one, so it makes it even more confusing. But it's helpful, I think. We wanted to provide some background information to our section members so that they know what AI is and how to take advantage of it. We have many members of our section who are doing studies with this, or helping industry develop AI models. But then there's a lot of other things that we can just use regular, like large language model, things like GPT, to help our lives be a little bit easier, right? And so I think the first thing a little bit is to understand, like, what is AI? What are the different domains of AI? Maybe I want to help do development of AI products in the point of care ultrasound space. So educating our section there, but then leveraging other AI things to help us. So I'll give you an example. So our infection prevention subcommittee put together using Google LM notebook. They put together, like, they took all the policy, they put all their communication to help put it into this Google LM notebook. And essentially, if you can now query that program for any infection prevention related item, and it will, it's a focused AI product. It will create a policy for you. If you wanted to have it, there be a quiz because you wanted to torture your residents, you could create a quiz. If you wanted to respond to a concern that your infection prevention people, you could put that in there and it would give you a response. And so anyway, I think we're trying our best to educate our section and give examples of how AI can help them with their job and in their domains. And that includes, like, I think it's helpful to understand, like, what are those development domains? Sort of some, like, really baseline understanding. The other thing that we're doing is we're working together to publish a white paper that I hope will come out here in the next couple of months that give some background to where we think AI fits in the point of care ultrasound space, like what things where AI would be helpful to create some suggestions and standards for development of those things as well. And so, AI is, every other week it's changing so much, but at least we are trying to provide direction and define how this is going to help us, instead of having developers define that for us. So that's
Yeah,
what
and
we're
I
trying
think
to
that'll
do.
be really important going forward, is letting us define the standards and see what we want so that it's
Right.
helpful, as opposed to the insurers or the billers or someone else, which I feel like is where the EMR goes.
Well, I don't think the EMR companies are asking us questions. They're telling us what we're going to do.
Well, I'll just put a little suggestion in there. Can we get like the arrow sign that I used in medical school, where the fracture was on the x-ray that the
Yes,
radiologist
exactly.
would put?
Right.
Can we have AI
Yeah.
put that for me?
Yes. We're going to actually have it color it for you. Highlight it in yellow.
And then make sure that not every artery is red, not every vein is blue, and not every ureter is yellow.
There you go. Well, you can mix it up. Maybe it's your choice of color palette, right? AI will log in and will know Laurel Barr likes a pastel color palette, and then it will put whatever you want. I don't know.
Which are exactly the things that every time my EMR updates, I completely ignore.
Yeah, that's fair. I want to see patients, not deal with all this stuff.
Anyway, I don't need to bash on technology right now, but um, so sounds like your section is doing a lot to advance the future of the specialty, particularly in POCUS and in ultrasound and EM. And you're doing that within ACEP as well as outside of ACEP. So tell me about ways you collaborate with other organizations to advance the specialty.
Yeah. So, yeah, I really think that the ACEP Emergency Ultrasound Section is the leader in point of care ultrasound. Period, full stop. So that's within emergency medicine and outside of emergency medicine. I think those, like I said, those emergency ultrasound guidelines have formed the core of helping to define what point of care ultrasound is and how we privilege physicians for doing it, standards around who should be directing it, all of that, and what education standards should be. So we talked about infection prevention. We work with AIUM, which is American Institute in Ultrasound and Medicine, and other emergency medicine organizations, and even other outside of emergency medicine that deal with ultrasound guided procedures to help create policy statements or joint professional society statements, like what best practices are and what they should be. We've done a lot of work in the past few years with an international organization called Integrating the Healthcare Enterprise, which develops engineering standards for workflow. So it's all the back end informatics stuff that's on the ultrasound machine and within the EMR to make sure that the ultrasound machine can talk to the EMR and a PACS system or your sort of PACS manager, whatever that program might be. So we've done a lot of work. The purpose we've done all this work is to make physicians' lives easier, right? It's until you have some like nerds and geeks in the group that are willing to like get down to like the brass tacks and talk to the engineers, talk to the policymakers and whatnot. Like you need those people so that they provide the physician perspective. So just like you're talking, Laurel, with like the EMR, do the developers of the EMR listen to physicians or physicians that are actually doing it, right? I mean, that's the challenge. And so our goal is to get those people in with the nerdy groups, right? The engineers, the other sort of people that are in that kind of space and say, hey, like, let's learn, we'll speak the same language. And did you think of this? And what we found is that that makes a huge difference, right?
Mhm.
And so working and partnering with those organizations is great. And ACEP has been fantastic um, to want to collaborate with these other large international organizations to help. And so it's already made a big difference, and I hope that it'll make a big difference as we move on to make our lives easier, so that the equipment that comes out and is produced helps us do our work faster and more efficiently, rather than having a bunch of ridiculous steps that don't need to be there.
Yeah, I totally agree. I don't think the stereotypical ER doc really is the personality of, base jumping and biking onto the computer to do the background work. So I appreciate that there are other people out there that are doing that because I just really want to go in, throw the probe on the patient and go, aha,
That's exactly right.
now I can get this moving.
Yes. And make it easy, right? Because
Right.
we're we're trying to solve too many of the world's problems that it would be nice if we didn't have to do it all at the same time, right? We can break it up a little bit. And that includes some of base jumping and, parachuting, going to space, all that other stuff. So with
All
option, of
we
course.
can do as emergency physicians if we choose.
Yeah, that's right.
Well, sounds like really this section helping to make ASEP a leader has been making ASEP a leader in this. How do you think your involvement in this section, since you started out so long ago, has impacted your career?
That's a great question. I feel like for me personally, those two main best parts of this section. Number one is just the people, right? I mean, it's just the opportunity to collaborate with just amazing people from other institutions within ACEP, or that are a part of ACEP. um, so that's been really helpful because we're all at our own individual shops, and it turns out that we have similar problems. And the section is a great place to find similar people, like-minded people that are also trying to do this and may have solved the same problem in a different way. And so that's really good. So, just a listserv in and of itself is a great way to communicate, to say, hey, I'm having this problem. Like, what did you do? How did you address this? We get this a lot with sort of billing and coding, which is like, hey, my billers and coders are saying that we can't do X, Y, or Z. And people be like, well, actually, look at this statement published by CMS about X, Y, or Z, or it's infection prevention. So I think just talking to people, collaborating, helping to solve, local problems that you may be having is number one. The number two thing is it's a great opportunity to, advance and grow your career, to be mentored, right, by people that have done similar things. So we've got a subcommittee that's involved in undergraduate medical education. And so as Point Carroll Son has grown in the undergraduate medical education space, we have a subcommittee of people who are involved in that. And so what's really great about that is that we have people that love medical student education. They're just doing the point of care ultrasound flavor of that. But then they're having the opportunity to talk about, well, how do I grow my career if I want to be an educator in medical school, right? Like, how do I advance that? Because I think a lot of us, like in the academic side, may look towards residency education, or, there's some fellowship opportunities, there's organizational leadership within, the clinical context, but the medical school is another space. And so a lot of people who end up being interested in medical student education, they can get mentorship and other ideas. I mean, that subcommittee usually does a webinar every quarter where they talk about some of these things. And so it's a great opportunity to grow. And so I think number one is the people, most importantly is the people, but also it's opportunities that ACEP, but that the section provides for me to get mentorship, and then, to have these roles and provide leadership and mentorship to other people as I advance my career.
Yeah, and medical students in my experience really love getting their hands on this. They might not all go into EM, but then they get a little bit of experience and they know what we can do. And then when I call them with my ultrasound results, they're not asking the radiologist to back them up at 3 a.m.
I mean, I had a couple, right? I had yesterday, I was doing some education, and there's someone going into child psychiatry. Right. And so they were like, I love ultrasound. I'm like, that's great.
I mean, that could be their whole physical exam.
I mean, I don't know, right? I don't know. It's like, I think there are worms inside of me. No, let's look. No, there's no worms inside of you.
I've used it that way before, actually. Usually ingested foreign bodies, but I've used it that way.
There you go.
Well, sounds like an excellent section. Really easy to get involved as a early career physician, even medical student residents. Sounds like there's subcommittees where if you want to get involved in this, you can get in, get mentorship, develop your niche, or even use your area of expertise, because you have an area of expertise in this area or in ultrasound that a physician who graduated 30 years ago probably doesn't. So leverage that, get involved. I believe you said it's Julie Rispoli to contact if you want to join a subcommittee or get involved in the section.
Yeah. So Julie Rispoli is our ACEP liaison, but you can always reach out to anybody within the leadership, but Julie's the liaison to help. And so if you go to the ACEP Emergency Ultrasound Section webpage, you can see the different subcommittees that are there. But we love students, we love residents. I think what's particularly valuable about students as we continue to push point of care ultrasound into medical student education is we love their feedback and their help, especially as we think about this new era of technology where everyone's going to have an ultrasound machine instead of a stethoscope.
We might already be there. I'm not sure. All right. Well, thank you so much for your time. I want to ask one last question. What is your favorite ultrasound scan to perform?
Oh, that's great. That's a great question. I like echo. I mean, I like cardiac ultrasound the most. I think primarily I use it the most because I think it provides that information that it's hard just to get from physical exam and history alone. So, I mean, I think that I use it in a lot of different ways. Like we get young people that are anxious that come in with chest pain, and I'm like, hey, here's your heart. It looks really good. Here's it's contracting well. It looks fine. I think it's an opportunity to engage them and reassure them that things are okay. And then, you know, I you have a 80-year-old that comes in and you don't know what their volume status is, right? I mean, and it's a little bit tough to know. So do you diurese them? Do you give them fluids? I don't know. So just put the ultrasound probe on, and I'm just answering a simple question. Is it squeezing good or bad, right? And is your IVC bigger, small? And so I think it helps. I like those are the things. I'm not doing like a full echo on everybody. I'm not pulling out and doing fancy stuff. I'm just trying to answer simple questions. And I find that one's the most helpful for me.
Yeah, totally agree. Especially the crashing patient. If I can do one ultrasound, that's probably going to be the one that saves the most lives. Because, like you said, what is this? I can get a lot of information in just a couple of seconds.
Yeah. Yep. Yep. I
All
think
right. Well, thank you so much for being with me here today.
well, thanks, Laurel. And yeah, always feel free to reach out to anyone in our section leadership and Julie Rispoli, who's fantastic.
All right.
Thanks
Thanks,
so much.
Rob.